The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon or good morning to everyone, depending on where you're at across the great country here. Welcome to our webinar today on transitioning to the value-based care for MACRA webinar, sponsored by EHR Integration Services and Project Navigation. We'll begin in just about 1 minute. So again, sit back, relax, and we'll thank you for being with us, but we'll get started in about 1 minute. Thank you. Again, welcome everybody. This is Jamie Steck, Business Development Manager at EHR Integration Services. We'd like to welcome you to our webinar this afternoon. And a couple of housekeeping items here for you. We do have everybody on mute today as we go through the presentation. We do encourage you to use the Ask a Question feature inside the webinar. That way, if we are not able to fully answer your question on the webinar, that we have a record of it and can follow up with you accordingly. So again, we'd encourage you to please use the Ask a Question feature. It's my pleasure to have with me today Rich Rutherford with Project Navigation. Like you see there on the screen there, he's our expert direction person for the transitioning to value-based care. Again, so next slide, Rich, I think, if you would, please. Just a brief history on EHR Integration Services. Again, most of you do know us and do know, and we have worked with you in the past, but Craig founded the company back in 2006. And in the heart of the revolution here of the healthcare industry and the healthcare space, we have approximately 55 FTEs, all very knowledgeable and very experienced in the healthcare space. Most of the consultants here have been in the clinic setting for 10+ years or more. We have a very large, wide, and broad client base across multiple states in the country. Our partners at this point is certainly our Bite-Size Solutions, our strategic partner on the development and the development side, excuse me. But our company here, we really revolves around three things, the three F's as we call them: faith, family, and fun. We do like to have a lot of fun together, and as we work together, we do take time to celebrate those moments which we can get together and have a great time and realize that we are family and we very much rely on each other. So that is our mantra: faith, family, and fun. But as we move into this and talk about today's webinar here, we want to talk a little bit about interoperability and what EHR Integration Services can offer and do, and what we're seeing here. We really do see that all of these data points in the healthcare space are connected. And it's really being able to talk in and through these data points that really makes a big difference. And with our government and today's topic, you'll see how that relates from getting information from your EMR, regardless of what it is, and even your practice management system and the billing aspect of this through population health management and the front desk workflows. All of this comes together and really needs to be interrelated or interoperable in order for us to do well at what we do and how we are to help take care of our patients. So you're going to see a lot of that. That's really what we're focused on in 2018, is how we can help you as our clients and people there is to be more interoperable and connect all of these dots. Next slide, please, Rich. So again, we won't take time here, but just know that we do have, we do see that the breadth of the care settings is really what we need to focus on, because it's not just at one location in our clinics that makes a difference. It's really being able to tie all of these items across the care setting to really make sure that that's a smooth process, that everything is speaking to each other, and that we do have all of the information necessary in order for our providers and our caregivers to make good and educated decisions. So with that, I'm going to turn it right over to Rich Rutherford. He is the president and co-founder of Project Navigation. A good friend of mine. I've known Rich for a long time and had the great opportunity of working with him on a couple of different projects at this point, and very knowledgeable about this space, and I think will bring a great value today for us here. And just to let you know again that this webinar is being recorded and will be distributed to the attendees here today. So with that, Rich, I'm going to turn it over to you, if I would, please.
All right. Well, thank you very much, Jamie. And thank you for everyone in attendance, your time today. Project Navigation provides clinical project management services and advisory services. So advising on strategy and planning and executing through clinical project management services. So as we walk through the next couple of slides in our presentation today, keep that in mind. As Albert Einstein stated, we can't continue to solve problems by using the same kind of thinking we use to create them. And that focus is going to be throughout this conversation this afternoon. Our agenda for today includes 6 items. We're going to talk about taking a different perspective on MACRA, what value-based payment transition and the role of that within MACRA, and how it provides the foundation for value-based care. Then talk about 8 steps to mitigating the risk associated with value-based payment transition. 2 key findings for onboarding providers with implications as to how MACRA views that. And then talk about the future of MACRA. So we're all eagerly awaiting the 2019 proposed ruling, which should be out any day. But CMS has given us a lot of hints as to where things are headed, so we're going to spend some time talking about that as well. A change in perspective. So one of my favorite images or illustrations from MC Escher, and it's called Day and Night. And what's interesting about the illustration is that when you look at it, you can't look at the blackbirds and see the white birds at the same time. It requires you to change your perspective to see the other. The second thing is, from the bottom of the image to the top, the fields are transforming into the birds. So perspective plays a very important role in how we perceive what we need to accomplish and the challenges that are associated with it. So my goal today is to bring focus to the transformation that's occurring in healthcare through the foundation of MACRA and what we can all do to excel. Quality over quantity. I pulled this off of the internet, and I won't say where I got it, But is this really what value-based care is? That in order to provide high quality, it's over the quantity of patients that we can see? We don't think so. Value-based care is high quality, efficient care, meaning cost, that improves patient outcomes based on the services that have been rendered. So very important to make sure that there is clarity in the information that you're receiving into your organization that you're using to establish your plans and strategies moving forward. As a matter of fact, MACRA requires that there are beneficiary thresholds met in order to be included in the program. So volume plays a role, not the loss of volume. A lot of misinformation available. As we look at the items that make up value-based care, it's about receiving the value of the services that are rendered, and which is evidenced by high quality and low cost. I really enjoy Peter Drucker's books and quotes, and one of my favorites is, if you can't measure it, you can't improve it. And that is the foundation for MACRA. MACRA has a lot of challenges. Not only is it 3,000 pages long, hundreds and hundreds of slides of PowerPoint education from CMS, but we also have variables as it relates to interpretation. So vendors interpret the specifications, and then how the applications need to be configured is also an interpretation. And there is a lot of room for improvement in this area. I checked a lot of the organizations that are represented on this webinar and several that aren't to look at the mission statements that everybody has. And there's very common, similar themes throughout: to improve the well-being of our patients, to improve the well-being of our community, improving patients' lives. So as we look at the foundation of what MACRA is doing, there's a lot of challenges. But where it's headed is in alignment with the majority of our own mission statements. So we need to begin to change the perspective of legislation driving us versus us harnessing the capabilities of our organization to drive and fulfill the mission for which we were founded. As we look at cost and talk about cost, cost is a tough item, and we'll spend quite a bit of time today talking about it. You know, my wife is a student, or is a nurse at an elementary school, and she was required to get a TB test done. So she called her primary care provider, and they indicated that it was going to be the following week in order for her to have an office visit for the test to be performed, and then she would have to come back for the read. And the charges associated were the office visit and the test and the read. So she decided that she would call the urgent care clinic that's close to where we live, and they had it available right away, and it was $65 as it relates to payment. So she decided to also call Minute Clinic from CVS, and their fee was $35. So as we talk about cost, my wife made the decision to utilize CVS because of the cost associated with the care that she needed to get in addition to the convenience. So with patients having to pay out of pocket for high deductible plans, cost is going to play a major role in the future of where patients go for services rendered. So if cost hasn't come up in discussion or is not yet part of mission statements, it's something to give some time and discussion to, as it relates to where things are headed. When we talk about cost control, we talk about preventing exacerbations, reducing unnecessary care, a duplicative care that's happening. Quality, we talk about care coordination and looking and seeing the healthcare delivery process from the beneficiary's perspective, regardless of the hospital that they saw or their primary care provider or their specialist. So it's about the holistic view of the healthcare of the beneficiary. Preventative screening, such an important part of preventing unnecessary treatment, exacerbations, focusing on those preventative screening measures as it relates to measure performance. I don't think any of us, as we talk about those two categories, wouldn't indicate that absolutely there will be improved outcomes as it relates to those interventions going into effect for the patient population, which ultimately, if we catch things earlier, if we're screening and we're proactive in our plan of care, we will reduce the use and the cost of unnecessary services long term. But there's plenty of opportunity for sustainability as well as reduced cost. Value-based payment transition is really founded in MACRA, and there's been, while there's parts and pieces in some of the commercial plans, MACRA is really laying a foundation for how that is calculated and quantified and utilized from a comparison perspective. So that's why I really say that MACRA is the foundation for value-based payment transition. MACRA is the most significant change to the physician fee schedule in 26 years. So if any of us thinks that our current operations is sufficient for transitioning, then we're in for some real challenges. On the left-hand side of the screen, the advisory board put together a graph based on MACRA being released in 2015 and estimated that Medicare payments tied to risk models for this year would be at 50%. And the commentary on the ruling and so forth afterwards was that that was unbelievably aggressive to see within a 3-year time frame, actually a little bit less, that we'd be transitioning from fee-for-service to that much of Medicare payments tied to risk-based agreements. So what's interesting about this is, fast forward to today, 2018, CMS is estimating 250,000 physicians will risk 8% of Medicare revenue, which will qualify them for the thresholds to become qualifying participants out of approximately 600,000 providers. So if you do the quick math, that's about 41%. So that is much more in alignment with those original estimates than I think what I definitely thought where we would be at for this year. One of the biggest challenges that we have with moving into that value-based payment transition towards that advanced APM is the fact that there's thresholds that have to be met. As of right now, it is a little challenging, depending on the Medicare mix of patients that you see within your advanced APM, depending on the type of advanced APM, to really meet those thresholds individually. However, very soon in 2019, the other payer advanced APMs become available, which will include Medicaid and Medicare Advantage programs. And that will be then followed by commercial payers in 2020. So there's an opportunity between now And when the lump sum payouts for qualifying participants ends in 2022, based on the performance year, to take advantage of the 5% incentive that is available. The absolute deadline in transitioning into value-based payment is 2026, where the physician fee schedule will increase to 0.75 for those status as QPs and decline to 0.25 for non-qualifying providers. So within the window of today and 2026 is when the transition must occur for sustainability of your organization. MACRA, as I indicated, plays a really important role in the foundation. So this is a little bit of an eye chart. It is very challenging, I must say, to get a single image that displays what MACRA is from a foundation perspective, but that's what we've attempted to do. And I'm going to walk through each one of these boxes through the different agreement types so that there's clarity from a foundation perspective on what MACRA is and how it works. So once you have these fundamentals understood, then the ability for you to apply the unique characteristics of your organization on top of that becomes much easier. So the objective here is to ensure the foundation is present so that you can build from that foundation into the uniqueness of your organization. So as I walk through, I'm also going to move with a spotlight so that you're able to follow box to box as we move through the diagram. MACRA requires thresholds for provider participation. So Medicare Part B billings greater than 90,000 and greater than 200 beneficiaries per individual or group. Group gets a little unique, so be careful as it relates to your organization. And I can't call out every caveat as we move through this, but this is the foundation for you to begin to assess the impact for your organization. Then determining on the CMS agreement type, 3 types. Now, most of this is presented as 2 tracks. You've got a MIPS track and you've got an APM track. There really is a hybrid third, and that's the MIPS APM track. So within those 3 tracks, they progress from MIPS to MIPS APM to advanced APM, which is a progression of the value-based transition. So following down the left-hand side of the diagram, MIPS, I want to call out a revision based on the 2019 Medicare Hospital Inpatient Prospective Payment System that was released 2 weeks ago. The Advancing Care and Information category has been renamed to Promoting Interoperability. There's been no additional changes as it relates to objectives associated, but the name has changed in alignment with the inpatient meaningful use and quality programs. So that gives us an indication of CMS aligning hospital and ambulatory type of definitions, which I think is a welcomed need as it relates to treating the beneficiary across the healthcare spectrum. Moving down, so we have promoting interoperability at 25% over 90 days in duration. For 2018, quality, 50% of the score over 12 months in duration. Improvement activities, 15% over a 90-day duration. And cost at 10% over 12 months duration. The culmination of those 4 categories then goes down through MIPS scoring standard and generates a composite performance score, so the CPS score. The CPS score then has payment adjustment definitions defined. So for this year, if it's less than 15 points, you will receive a negative 5% payment adjustment, and that will be applied in year 2020. 15 points is a neutral adjustment. 16 through 69 would be positive, possibly, and not meeting exceptional bonus criteria, and 70 or greater would qualify for the exceptional bonus. So let's talk a little bit about expectations around incentive payments. The overall consensus is that there will be minimal incentive payments received for any type of a score less than 70. So we say, well, why is that? Since MACRA is a revenue neutral program, the expectation is that the penalties and the dollars from penalties are utilized to provide performance positive benefits for providers from 16 through 69. So because the expectation is that not many providers will be penalized because of the easy nature of the program for this year, there will not likely be much of an incentive below a score of 70. For those that score above 70, there is an exceptional bonus allocation of $500 million from CMS. However, the challenge now with this is that the distribution of scores are highly concentrated at the upper level of the CPS score, that the distribution will be across many, many providers, and therefore the individual incentive dollars, even greater than 70, is likely to be relatively minimal. So as we look at progressing from MIPS to MIPS APM into advanced APMs, the incentive allocation of the 5% on the advanced APM is much better opportunity from an incentive perspective, while there is risk, than on the MIPS track in general. Now, CMS revises that in 2019 to reduce thresholds for more providers. There may be penalty allocation that will support additional bonus dollars, but as of right now, it does not look like that. Back to the top of our diagram, moving down the MIPS APM track, this is that hybrid track of you're not exactly MIPS, you're in the MIPS scoring standard, but you pick up benefits because you are in a MIPS APM scoring standard. So this is most commonly your MSSP track 1s, track 2s, minimal risk, some shared savings is this track. Now there are benefits. We pick up the promoting interoperability, and I will state that 25 needs to be 30%. So if you're seeing that, we'll make the revision in the presentation for promoting interoperability. That is over 90 days, quality, multi-utilizing the CMS web interface for 50% of the score over 12 months, and improvement activities 20% over 90 days in duration. But you note that there's no cost there. So there are benefits to APM scoring standard over the MIPS scoring standard in conjunction with reporting as a group via the CMS web interface, which has flexibility on the number of beneficiaries that you have to report in, and other elements that make it advantageous for utilization. The MIPS APM scoring standard then picks up the APM rewards, as CMS calls it, and then they fall into the same CPS score and distribution as our MIPS provider track does as well. Back up to the top of the diagram, advanced APMs, they're included in the agreements with CMS is margin and minimal loss agreements. Quality is required with performance, typically submitted via the web interface, 12 months in duration. And CERT is required for use on the EHR for at least 50% of the clinicians. As we move down through the performance thresholds for the advanced APMs, 25% of payments have to be from beneficiaries, or 20% of the beneficiaries in the population seen needs to be inclusive of Medicare beneficiaries. If that threshold is met, which CMS has just this week updated the QPP website for MTI lookups. So if you have not gone out and are trying to understand what your status of your providers are, you can see if their QP status based on the first snapshot that occurred the end of March for performance year 2018. So utilizing those tools in tracking where your provider is becomes very important to understand if they fall out of the advanced APM track because they're not meeting thresholds. If they meet the QP threshold, they will receive a 5% incentive that will be paid out in 2020. There is also a secondary threshold for partial qualifying participants that is 20% of payments and 10% of beneficiaries. So it's a little bit less than the advanced APM. If the provider qualifies for the partial qualifying participant, they then have the choice whether they do not participate as a MIPS APM in the MIPS APM track, or whether they do want to participate. If they do want to participate, they also have to submit the data associated with the MIPS APM track so that their CPS score is reflected correctly. So understanding a QP to partial QP, those thresholds, and if in the advanced APM track, an individual provider, depending on the type of advanced APM it is, could fall into the MIPS APM track for scoring standards if they don't meet the QP or partial QP threshold criteria. So that requires a little bit of juggling and planning if you've got providers that are on the line or not completely into or qualified as a QP or partial QP. So the cyclical process of how advanced APMs work, the tracks between MIPS, MIPS APM, and the progression to the advanced APM, based on this information, you can then take and lay over top the foundation, the uniqueness of your particular facility to further understand exclusions, small practice providers, bonus opportunities, improvement scoring opportunities. Those are all minor tweaks, but this is the foundation for which everything in MACRA resides on top of. So if you understand this, you'll be able to understand other intricacies and then better plan for where your organization needs to be to ensure optimized performance regardless of track. Let me move back to our mouse. So where do we begin? I want to talk about 8 steps that are important as we look at where do we go from here. So we understand the foundation of the program. What do we do? In alignment with our mission statement, these things all align to where we want to be heading as an organization, regardless of what legislation is driving us towards, which we have to meet as well. We need to maximize the capabilities of our platforms. we need to focus on closing clinical quality gaps at the point of care. So there's so much overhead in addressing gaps in care after the patient leaves the practice that it's worth the effort to address them at the point of care. Provide meaningful and actionable feedback to clinicians. We need to align our organizations and our roles and responsibilities to prepare and execute effectively in this new model. I can't tell how many organizations are still in their same org structures that they were 10, 15, 20 years ago. And healthcare is changing dramatically, and we need our structures to reflect those changes so that we can be nimble and effective in the changes that we make. We need to understand the cost and the quality of care being delivered, focusing on care coordination for those high-risk patients, partner with community healthcare organizations for that holistic approach of the beneficiary, and determine the level of risk that each of our organizations is willing to take and can manage effectively. The first area as it relates to addressing elements at the point of care in the EHR tools is really aligning workflows to address our ECQMs, clinical decision support, and clinical protocols. They all must be fully utilized in order to close gaps at the point of care. I want to call special attention to any organization that is submitting claims-based information either in an ACO or directly through the MIPS track, that there are significant changes expected for topped-out measures in claims, in that 70% of the existing measures today are considered topped-out, expecting that 52 of them are going to be removed by 2021 if CMS doesn't move more aggressively in their topped-out measure approach. Claims-based reporting has its own challenges and how it works with clinical decision support tools in our EHR platforms, modifiers instead of SNOMED. So all these intricate challenges that we have, if you are currently submitting via claims, it is imperative to begin evaluating and driving forward with clinical ECQM measures, measure specifications to fully utilize the tool set that you have available in your application. Ensuring that clinical data is captured and codified for dashboards and for population health tools. So there are a multitude of free text areas, things that are just not codified. They don't feed measure specs, and they don't enable us to utilize the data because we don't know what it is as it relates to dashboards and population health tools that can service us in further targeting and refining our risk-based strategies. And we must establish clinical protocols to evaluate cost and outcomes for 4 key disease areas, including diabetes, COPD, coronary artery disease, and heart failure, which are 4 disease areas that CMS is focused on from a cost perspective. The feedback that we provide our providers needs to be real-time or near real-time in order to close gaps in care. So many of paper reports that are coming out and analytical reports, and it's not incorporated into the plan of care. The feedback isn't timely in nature, and it's not seamless to the provider, doesn't provide the feedback to entice the provider to continue to make improvements because they're just not clearly aware of where they're at today. Patient measurements improvements, really explaining improvements in measure performance and how it impacts and improves patient lives. Like the number of breast cancer screenings present X number of malignancies, late termination or late identification. Presenting information in that fashion connects with the provider and speaks to the core of why they became a provider. So making sure that data is presented in meaningful ways to physicians. I spoke a little bit about aligning organizational roles, and want to emphasize here that it is imperative, as quality becomes the foundation for reimbursement, that there be change control that evaluates changes and its associated impact to quality implications. So more structure and focus as it relates to that will help prevent us from causing our own issues as it relates to things that we're introducing into workflow configurations, upgrades, etc., with our software platforms. Cross-functional teams and resources need to be working together effectively through quality initiatives. Clinical operations knows best on how to integrate software into workflow and process. And then tracking initiative performance must be operationalized across the organization. And by across the organization, we're talking incentives, physician payments, staff incentives, so that everyone's in alignment in the pocket and from a patient perspective, driving things forward to improve the quality of care for our patients. I dedicated a slide here to cost because cost is one of those difficult things that none of us have the full picture of cost for the beneficiary. So Medicare and CMS obviously has the full picture of the beneficiary, but we only see a sliver of the services that we may be providing. However, we do have tools and steps that we can take to begin to put and manage the risk that we've got associated with cost. The first one is taking a deep dive into the 2016 QRUR report. While at least a year old as of now, understanding the beneficiary cost attribution to your TIN is very important. Evaluating the hierarchical condition categories and their associated beneficiary score and the costs is also very important. Some of those beneficiaries are likely deceased. Some of those beneficiaries are still present, and you can use the information in the QRUR to understand and put together targeted care coordination plans to address that high-risk population, which also drives a substantial amount of cost. You must evaluate the cost of care for beneficiaries for our 4 core diseases, and the QRUR will outline your performance amongst your peers based on your treatment of patients with these diseases. That information can be utilized to backfill through your clinical protocols and understanding overall performance and gain insight onto how more effectively to manage cost for those diseases. Evaluating your admitting hospital episodes and those associated costs is obviously very important. That's where most of your cost attribution comes from, based on you being a primary and providing most of the primary care services for the beneficiary is how they're attributed to you. The second tool that can be utilized from a cost perspective should be available right around the corner. In July, CMS is supposed to be providing feedback for 2017, which will look very similar to our QRUR report. It must be evaluated to understand your cost implications for 2018, and obviously the 30% cost allocation for 2019. It becomes absolutely imperative to review the information and to adjust your organization as needed to mitigate cost implications, unless you're in the MIPS APM or advanced APM track, and then cost is already wrapped up into your other agreements. Commercial payer reports and data exports. So depending on your relationships with your payers, there is some opportunity to export data into an enterprise data warehouse where you can do your own cost evaluations. That's more of a broad recommendation depending on your existing payers and your relationship with them. But there is opportunity to begin to use information to more effectively manage the risk exposure as it relates to the cost category. Moving to care coordination, focusing on that high-risk population, I think makes complete sense for targeted care coordination initiatives. And focusing on that top 20% will get you that Pareto impact of that larger impact and focusing on the whole. Codified clinical data as it relates to output from your ECQMs provide an excellent foundation for risk stratification and for predictive analytics capability, as long as your data is codified, that can further harness your care coordination initiatives with data to be more accurate with who you're targeting and for what interventions. Community partnerships, very important. Beneficiary cost, is really out of your control. However, partnering with an ACO locally helps mitigate your risk because the ACO is also aligned with your same initiatives and cost control components. And understanding the attribution from providers, other specialty providers, and hospitals becomes very important. Look for opportunities for partnerships and acquisitions to help mitigate and manage and control those costs. I would also encourage the evaluation of social determinants. There was just a recent update regarding Medicare Advantage plan looking to provide funding for additional social determinants. So that will be up and coming as it relates to an opportunity for potentially additional income, revenue, and also for mitigating risk for beneficiaries. And then really understanding the amount of risk that your organization is able to take on. There's opportunities to establish ACOs, to join ACOs, join existing advanced APMs, or even establish your own advanced APM based on existing models that have already been approved by CMS. And then preparing for risk-bearing agreements if you're not already in them, and also be prepared for other payer advanced APMs in 2019 and beyond. I couldn't not include these two key elements for provider onboarding that I just think are so critical. First is that provider payment adjustments for previous year performance will follow the provider to the new TIN NPI. So if they received a penalty and they are now in your TIN, when the payment year comes, it's going to be applied to your TIN. If they received an incentive, that benefit will also follow. So as you vet your onboarding providers, it is imperative to know their performance in MACRA programs for at least 2 performance years prior to the current year, so that you understand what your payment year implications will be. Also, another intricate detail regarding QPs. So if you have a QP that joined your practice group health system, there is an opportunity that the payment, that 5% incentive, will be paid out to the TIN in which the provider is in, and it will be paid out based on an update to the CMS 588 electronic fund transfer form what CMS does with this, if anything, in 2019, but it could create some anxiety as it relates to some of the safety that's involved via submitting and reporting via the CMS web interface. And then the last piece here is that APMs are here to stay. So a lot of discussion on whether MIPS is going to stay and whatnot, but there's no discussion about MIPS or APMs going away. So that is the future. That is what CMS and MACRA is incentivizing and driving everyone towards. And it aligns with our mission statements of where we're at in our organizations. So I would encourage the change in perspective to not what CMS is requiring us to do, but how we're achieving our mission statements for our patients and for our communities. So the last thing I want to leave you with is the question, where is your organization? And I'll end with a story. 2 weeks ago on Friday afternoon, I received a call from a CEO very concerned about their organization and where they're at this point in the year. And what had happened was a peer organization had engaged a third party that had created a level of uncertainty about how advanced APMs, for this particular advanced APM, and how it functions. And that level of anxiety then stirred up the peer groups within the advanced APM to a point where they're reaching out to the APM directly in a panic over what was happening. And unfortunately, the anxiety was created for no value because it was untrue. It was an incorrect interpretation of how the advanced APM sees qualifying participants. So I bring up that story to say that your partners in where you're getting information is absolutely essential that it be founded on the truth so that you're able to build your organization's strategy and plan effectively and not be overwhelmed by fear or anxiety of the unknown. With that said, I appreciate your time, and I think we will open it up for questions at this point.
Thanks, Rich. Appreciate that. Again, we'll look to open that up for questions. There is one question here, Rich. So the question is how can project navigation help me navigate through all of this? What does a typical engagement look like? Where should I start?
Yes, good question. So what we typically do is first have an exploration discussion as to where the organization's at, where your objectives are, where you're heading, your service lines, your community, to understand, what have you done and what haven't you done. And then together we build a strategy and a plan that then we can either help augment the execution of that and or provide more of a hands-off advisory role as the organization implements the plan themselves. So that is typically how we approach those organizations that are, or if we don't even know where we begin, we just start with conversation and figure out, what do we need to do? We had one group from a year ago at the very tail end of 2017, and we were only able to get enough done to mitigate penalties. So you got to put it, the strategy that's executed needs to make financial sense. As we talked about the lack of incentive dollars being available, so don't overinvest if you're not going to get that ROI back out. So we work with the organization to institute and create a plan that makes sense on where we're going and makes sense financially as well.
Makes sense. Thank you. Next question is are there deadlines that I need to be worried about? What's next on the deadlines is generally the question here, Rich.
There are deadlines. So for this reporting year, based on your track, you would, and I'll just assume your MIPS track, that you're going to have to ensure that you have a full year reporting for quality, and you have a minimum 90-day reporting for promoting interoperability, the old ACI/MU category, and the improvement activities category. So 90 days both there. For that improvement activity category, you only need one NPI in your TIN to suffice for that category. So a lot of groups have gone totally overboard. Not saying that improvement activities can't be leveraged for clinical decision support and things of that nature across the enterprise, but your requirement is one NPI on the TIN in order to suffice for the improvement activity. So I hope that answers, and if it didn't, please let us know, and we can help provide some additional direction there.
Great, I appreciate that, Rich. Why don't there you go. So feel free to get a hold of me. Again, this is Jamie with EHR Integration Services, and we can get you in touch with Rich and answer any additional or further questions that you might have. Know that we also be posting this and getting the slides out to you for those attended to the webinar today. Doesn't look like we have any further questions at this point, so we'll close up and offer our thanks to you for taking time here today, and hope you have a great day and take care, and we'll hope to talk to you again soon. Thank you.